Good evening, everyone. My name's Pete Murray. I'm one of the public health physicians at Hunter New England. This evening I'll be giving a health protection update with a focus on vaccine preventable diseases. Thank you so very much for the opportunity to present tonight. Particularly like to thank the PHN and the immunisation team at the public health unit for organising tonight's update. Before I do get started though, I want to acknowledge that the lands that we're meeting on today are the traditional and unceded lands of Aboriginal nations. I'm dialing in from beautiful Awabakal country today. I'd just like to pay my respects to elders past, present and emerging, and also acknowledge and extend those respects to any Aboriginal colleagues on the meeting today and in attendance at tonight's session. And I'd also like to acknowledge the incredible work of the Public Health Aboriginal team at the Population Health Unit. So what are the learning outcomes and objectives from tonight's presentation? There are 4 things I'd like you to take away from my presentation. The first is to have an awareness of the current respiratory virus activity in New South Wales. That's COVID, influenza and RSV. Secondly, to have a better understanding of RSV and who's at most at risk of RSV and what new preventative tools that we have. We've got some new exciting tools as well. Thirdly, to provide you an update about measles and the current global situation and how that is relevant for us locally. And finally, to raise awareness about increasing pertussis notifications after a long period of very low pertussis activity. So before diving into specific infections, let's look at respiratory illness activity across Hunter New England at the moment. Before I look at the slide, I do want to acknowledge the flu tracking team for pulling this together. And I'd just like to acknowledge flu trackers out there. Many of you in the audience will be flu trackers or will have heard of flu tracking, a wonderful Hunter New England initiative. If you are interested in hearing more about flu tracking or in becoming a flu tracking participant, we can send some information out following this evening's presentations. Let's look at the slide in more detail though. This slide is titled Respiratory Illness Activity, and this graph is for Hunter New England. So this is Hunter New England flu tracking participants, the fever and cough rate that's being reported from our local participants. And what we've got on the horizontal axis is the month of the year. On the vertical axis, we've got fever and cough percentage, and we've got different lines which represent different years. So we've got 2022, 2023, and 2024. We also have the 5-year average here in the interrupted green line here. And what this is showing is respiratory illness activity over the course of the year for each year or year to date. And flu tracking has been the mainstay and one of our key surveillance indicators for measuring respiratory activity in the community. And it's very useful for monitoring respiratory activity during the winter months when we have our winter viral illnesses, but it's been incredibly useful during COVID when we've had quite atypical patterns with waves occurring in summer months of respiratory and illness that are due to COVID, as you can see here on this 2022 increase here. Now, key take-homes from this slide for us tonight is looking at the 2024 data. You can see that we started the beginning of the year with some elevated fever and cough rates in our community, but that this is tapered off and has now sort of leveling off here at just under 1% reported fever and cough rates in our community. So why this has dropped is mainly due to falling COVID levels in the community, but we now are just hovering below 1%, and looking ahead and thinking about previous winter illness seasons, we can expect this this line to go up and for fever and cough rates, respiratory illness activity to increase as we move into the cooler months. So what are the latest updates with COVID and influenza? Firstly, looking at COVID, some good news. We're over the wave that impacted us in Christmas and New Year's, and now we have low levels of COVID activity across New South Wales. We're often asked about what was the dominant sublineage that was driving the most recent wave we've had, and I've got a graph here of a COVID whole genome sequencing results. Unfortunately, my face is covering part of the graph, so I do apologise for that. But on this axis, horizontal axis, we've got time going back to the 5th of August, and on this axis, the vertical axis, we've got the percentage of sequences, proportion of sequences. What I just wanted to highlight here is this mustard colour, that since early December, this mustard colour has taken off and become the dominant sublineage. And this is the JN.1 sublineage that is now the dominant sublineage of COVID in New South Wales, and is also was the driver of the most recent wave that we had. It's also been driving COVID waves in other jurisdictions as well. Now, we're often asked about what the future holds with COVID, and it's very difficult to get accurate modelling. The modelling is very uncertain in this space, but what I can say is that we should start preparing for another COVID wave in the next 6 months or so, much in keeping with what we've seen over the past few years. We're watching very closely variants and sublineages, and at this stage there's no heir apparent to the JN.1, but as I say, we're watching that very closely, and we'll keep you updated if anything changes in the space. The other update is that ATAGI has released the 2024 COVID-19 booster advice, and now the Australian Immunisation Handbook has been updated to reflect that advice. I'd just like to encourage you to go back and reference that advice, review that advice, and also look at the Australian Immunisation Handbook as well. This booster recommendations covers off all the groups that are recommended for boosters, or where boosters should be considered. I think it's really important to highlight the group that needs to be considered, is recommended to have a booster every 6 months, is those aged 75 and older. And so that's an active recommendation for that group to have a booster every 6 months. It's also important to highlight that the ATAGI has reaffirmed their preference for the XBB.1.5 monovalent vaccines as well. So there's been a lot of movement in the ATAGI advice, and I just encourage you to look at the most recent information from ATAGI and also the Australian Immunisation Handbook for further details. Moving to influenza. So currently we have low levels of influenza across New South Wales, but we are seeing increasing activity as we head into the cooler months. So we should see influenza continue to increase. I think though this is a really important time to prepare for winter and to make sure we're planning our vaccination programs and making sure we've got measures in place to increase uptake in the groups who are at highest risk of severe disease and those groups that are funded for a free influenza vaccine. It's important to note that sort of globally, there's a debate around the quadrivalent vaccine. So the current quadrivalent vaccine that has been supported by ATAGI for use this influenza season has two influenza A-like viruses and two influenza B-like viruses in them. However, one of those B sublineages, the B Yamagata sublineage, hasn't been detected globally through surveillance for a number of years. Hence, it's functionally extinct, and expert groups globally are discussing what should be in the future seasonal influenza vaccine. So this is something that we could see some movement in the space, and or potentially could see the B Yamagata-like virus omitted from future vaccines. So watch this space. Let's now focus on another respiratory virus, respiratory syncytial virus. And the reason why I want to cover this off is we've got some new exciting preventative tools for RSV available to us now. And RSV has a huge burden of disease, and I'm going to talk through the burden of disease and talk through some of these new therapeutics in this new exciting space. Before I do so, I just want to highlight that this is the RSV virion structure. So this is what a very small single RSV virion looks like. And I want to highlight here two things: the attachment glycoprotein, or the G, and the fusion protein F. And the reason why I want to highlight these two things before I go talking about RSV in further detail is that these are the critical components of the virion that allow the virion to attach and invade and infect cells. And the critical thing that's a target of these new vaccines and these new monoclonal antibodies is this fusion protein here, F. And I'll talk about that in a bit more detail as we move through, but I just wanted to give you a sense that this is the critical protein that we're talking about this evening on RSV, and is the target of vaccines and our monoclonal antibodies. Let's now look at RSV's burden of disease. So RSV is a generally seasonal virus with peak activity from April to September. If we look at our current surveillance indicators, we have high RSV activity currently across New South Wales. This graph here shows RSV notifications by month. I think it's important to note that RSV was only made notifiable in late 2022. But if we look at this graph, we can see that our numbers and notifications have increased quite significantly over the past few months, which is again highlighting the high level of activity currently seen. Looking at impacts of RSV disease and burden disease patterns, the impacts disproportionately fall into two groups: infants and young children and older adults. In infants, it classically presents as bronchiolitis but can cause other lower respiratory tract infections such as bronchitis and pneumonia, and it's the leading cause of hospitalizations in infants and young children in New South Wales. When thinking about risk factors for RSV in this group, age is a critical risk factor. The younger the infant, the higher the risk of severe outcomes with RSV. Other comorbidities that are really important risk factors include prematurity, chronic neonatal lung disease, certain heart conditions, and certain immune conditions. But there's also other conditions that put infants and young children at risk of RSV. One of the areas where there's been a lot of development is in our understanding of RSV's burden on older adults. So in adults, RSV generally presents as an upper respiratory tract infection. But in older adults, particularly older adults with comorbidities, RSV can cause a lower respiratory tract infection. And key comorbidities we're concerned about here are respiratory disease and heart disease. And it is a key driver of hospitalizations in older adults as well. This is an exciting but busy slide, and I won't dwell too long on this, but it was prepared by PATH and it was updated earlier this year, and it shows all of the RSV vaccines and monoclonal antibodies that are either in development or market approved. And what's exciting is that there's a whole host of different vaccines and immunoglobulins undergoing phase 1, phase 2 and phase 3 trials, but also that there are a number of vaccines and monoclonal antibodies that are currently market approved, including in Australia. And I'm going to talk in a bit more detail about what's currently available in Australia. Let's start by looking at the RSV vaccine for older adults, or Arexvir, that's now available, and we have ATAGI recommendations for its use. And I've summarized the recommendations here, a little snip from the ATAGI advice. This vaccine is really effective at reducing RSV-associated lower respiratory tract infections in older adults. In fact, reduces the risk by 83% and 94% less likely to have severe RSV-associated lower respiratory tract infection. So very effective vaccine. Importantly, what's being studied is its impact over subsequent seasons, and it's shown to have moderate efficacy through 2 seasons as well, which is really promising. Now, Arexvir is available on the private market. It's not currently available on the NIP, but this is something that I think will generate a lot of interest, and it's a really effective vaccine in older age groups, and we currently have recommendations around its use from ATAGI. So having covered off the new vaccine that's available for older adults in Australia, let's now turn to what's happening with infants and young children. Now, for a long time, we've had available a monoclonal antibody for RSV called palivizumab, and that has been available for children who are at the highest risk of severe RSV disease. But it needs to be given monthly, and it's an incredibly expensive monoclonal antibody. There is now a new monoclonal antibody that's available called nirsevimab. And this is a single dose monoclonal antibody that targets infants and young children during their RSV season, and it offers long-acting passive immunity, and it's highly effective at reducing the risk of hospitalizations once administered. And the target of this monoclonal antibody is against the fusion protein on the RSV virion, which I've just highlighted here. So basically, it's a preformed antibody that you administer to the infant that's got a very long half-life that targets that fusion protein, stops the virus from being able to infect cells. Now, what's exciting about this new monoclonal antibody is it's got a very long half-life. So it lasts the RSV season, so it lasts 5 months, and it's incredibly effective. So we're looking at some of the trial data. It reduced hospitalizations by up to 80%, and real-world data is looking more promising, with some early data from the CDC showing up to 90% effectiveness in reducing the risk of hospitalization. So incredibly effective new agent that we have available to us. So nirsevimab, given how effective it is and given the burden of disease in infants and young children, has been incredibly sought after globally. There is limited supply globally. It's not available on the NIP. It's also not available on the PBS in Australia. It's not available on the private market either. However, some states are making nirsevimab available this RSV season. In Western Australia and Queensland, all newborn infants and medically at-risk children are able to access nirsevimab. In New South Wales, medically at-risk infants and children are able to access nirsevimab this RSV season, and that's been made available under the RSV Vulnerable Babies Program. So in New South Wales, this Vulnerable Babies Program is being led by the Children's Hospital Network and clinicians in the Children's Hospital Network. Some other private hospitals too will have access to this, but it is being led out of secondary and tertiary care. It is being rolled out in phases depending on supply and availability of nirsevimab, and it will be available in the Hunter New England area through the John Hunter Children's Hospital. Now, given that there is limited supply, experts in the space have crafted eligibility criteria which target nirsevimab to those who can benefit the most from it. Now, looking at the eligibility criteria for nirsevimab in New South Wales, the key groups to be eligible for it are all premature infants, less than 37 weeks gestation at birth, born after the 31st of October 2023. It's on this line here. All Aboriginal and Torres Strait Islander infants born after the 31st of October 2023, and other vulnerable infants, including children and infants with chronic neonatal lung disease, infants with hemodynamically significant congenital heart disease younger than 24 months, and a host of other conditions as well. So the eligibility criteria in New South Wales are targeting those who are most at risk of severe RSV this season. I'm just cognizant of time, and I've got two other issues to cover off, so I'll move through these a bit quicker. Just want to talk about measles first. So measles anywhere is a threat everywhere. And this graph here shows World Health Organization data over time, looking over years and months, and case numbers on the vertical axis. And what I want you to take home from this is in 2019, we had globally had a huge number of measles cases reported, over 540,000. But during COVID, as the border restrictions and public health and social measures were implemented, measles activity decreased substantially. Over this time, also surveillance was disrupted, so we didn't really have a good feel for what was going on. But what was also disrupted during COVID was routine childhood immunisation programs. And over COVID, and because of COVID, millions of children missed out on measles-containing vaccines. And measles is incredibly adept at exploiting immunity gaps. And what we're seeing now as border restrictions are lifted, with greater movement and people are travelling more, and public health and social measures have been lifted, is measles cases are correspondingly increasing and exploiting that immunity gap. And what we're concerned about now is that we're starting to see a number of importations into Australia of measles, but that this trajectory might continue to go up, and we may be seeing another 2019 epidemic of measles. But and that's what we're concerned about. So I just want to reiterate the threat of measles to you all tonight. So in Australia, we're very fortunate. We've been verified as having eliminated endemic measles. And we did that through maintaining high levels of population immunity through vaccination. And measles vaccines are highly effective and very safe. Currently in Australia, we've got a 2-dose measles-containing vaccine schedule, one at 12 months, one at 18 months on the NIP. But I did want to highlight to you that if you have infants and parents of infants who are planning overseas travel, and these infants are aged 6 to 12 months, they can have an MMR 0 dose, which can offer life-saving protection if they're traveling overseas. Now, this is called an MMR 0 because they still need to have the 2 doses as per the schedule when they return from overseas. So this dose at 12 months and 18 months. But this is an important thing to consider if you've got infants who are traveling overseas from 6 to 12 months. The other thing to ask is if you've got patients who are also traveling overseas, adults, adolescents, to just double check whether they've received 2 doses of measles-containing vaccine as well before they travel. So whilst Australia has eliminated endemic measles, we're still at risk of measles importations from overseas, and that risk increases as global case numbers increase. Here's a couple of headlines from New South Wales Health media releases alerting the public to measles cases and to exposure sites, and these have just been from March alone, so we are seeing a number of measles importations recently. And my take-home message for you is to be alert for measles. Consider measles in someone who presents with a clinically compatible illness. Ask about recent overseas travel, or if anyone in the household has travelled overseas. Ask about vaccination status, or look on air and check vaccination status. What we know, looking at measles cases in New South Wales since 2022, just over 90% are either not vaccinated or have an unknown vaccination status. Also ask if they've been to any areas that are listed in recent measles media releases as well. Now, if you're concerned someone's got measles, critical step is to isolate them immediately and then to notify the public health unit promptly. Prompt notification and isolation can help reduce the spread in the community and help reduce the risk of measles to the community. Public health unit can advise you on next steps and also can advise you on testing for measles and what the appropriate tests are. So yeah, just really wanted to highlight that measles is a constant threat, and I just encourage you to be alert to measles. Finally, I'd just like to raise awareness about pertussis. We are seeing increasing pertussis activity across New South Wales and also in the Hunter, New England area. This is demonstrated clearly in this graph, which is pertussis notifications in H&E going back to January 2022. You can see here that over COVID, when we had strong public health and social measures, we barely saw any pertussis. In fact, there were some months we had no cases notified through. But that has changed, and we're seeing a sharp uptick in case numbers. And this is being mirrored across state surveillance as well. And we're concerned we may be entering a pertussis wave, or pertussis epidemic, which we used to see every 3 to 4 years. Now, when thinking about pertussis, our priority group to protect is infants, and particularly those infants under the age of 6 months of age who are the most at risk of severe outcomes with pertussis. And our critical tool that we have to protect these infants is vaccination, and particularly making sure that vaccination during pregnancy, that helps protect the newborn and the infant when they're young, but also timely vaccination and NIP vaccines during infancy, childhood and adolescence. But also think about other groups that are recommended in the Australian Immunisation Handbook: new parents, grandparents who might be recommended for a booster too. That's a critical group that can help protect the vulnerable infants. And finally, I'd just like to highlight that if you do have someone with a clinically compatible illness, consider pertussis as a differential and order a PCR, respiratory PCR, and make sure pertussis is included in that testing panel. Thank you so very much for your time this evening. We've covered off some really important health protection issues, and I hope it's been a useful presentation. I do apologise for being slightly over time. Unfortunately, I'm not there in person or in attendance virtually, so if you have any questions, please send them through to the immunisation team, and we can follow that up later on this week and next week and get back to you. Again, thank you so much for your time. I hope you enjoy the rest of your evening and have a lovely week. Bye.